wound care for, but he was royal, so we did. So I promoted most wound management by coating packing strips with triple antibiotic ointment. You can imagine how expensive that was, and he even commented, you can't just keep doing this. And it was certainly not sustainable. But I inserted that into all the cavities with so much ointment that it would stay wet and I could easily remove it. But still, the dressing changes were painful and time-consuming. However, because it was truly wet wound care, the wound did close. So, what were the benefits of all that time that we spent with this patient and that expensive dressing technique? So the clinic staff constantly remind me that I was helping a guy who wasn't really a very nice person. However, compassionate care provided many kingdom benefits. I'm listing only 5 here. So the first is that the patient's son-in-law was a top pediatric neurosurgeon in Accra. And he came up to check to see what we were doing with his father-in-law. Well, about a year later, we had a patient who had a neuroblastoma myomeningocele, and she needed emergency neurosurgery from a pediatric neurosurgeon, and I had his phone number, and he owed me a favor. So that little girl was helped because of helping this man. Good wound care takes time, so relationships are developed. So even though our patient was a committed Muslim, and he had even been on the Hajj to Mecca, we prayed for him in Jesus' name after every visit. And if we started packing up before we had prayed, he would remind us, you left out the prayer. So we were also our patients' personal guests at the most important annual festival for the entire Dagomba tribe. For those of you who aren't from Ghana, it's about 2 million members. So every chief came to greet this man that we didn't know who was. And over we heard them say how glad they were they had been told he was dead. Introduce us to those people and say, it was because of these people that I don't have that wound anymore. And God was glorified, and people learned that the Christians had the ability to help people. We learned that this friend of the king was actually a title, and he was the king's senior advisor. So the king was very grateful, and that simplified our lives in many ways. And in fact, many years later, when we needed to do a research study in Dagban, we went to the king. Well, the king wasn't there anymore, but we went to the regent. And the regent said, I know exactly who you are. I remember Salufruti. Do whatever you want. So even before I came to the clinic, as I said, Peter was sneaking into the clinic before opening to take care of wound patients, and he was sitting on this I needed, because that way I could really see what was going on. So you really give the patient the message that you are washing their feet. Richard built cabinets and shelves so that we could convert a bigger area with better lighting into the treatment room, and together Peter and I managed patients, and they would travel from long distances to find us. Before she came to ours, and she came a few times to help me interpret early in the morning when I was doing wound care before I learned enough about Dagbani to kind of get by. And she was just amazed, and she said, I've seen wound care at all these other clinics, but I've never seen wounds actually close. And we said, well, that's because they weren't really being very careful, So Peter was deeply committed to teaching the gospel, and wound care was just an outgrowth of that passion. In the fall of 2003, Peter left for a year to further his education, and Asana became my wound assistant because I was doing it all myself by then. And she handled the routine dressing changes while I took care of the more complicated ones. And by the time we left Ghana, we were seeing between 6 a.m. and when the clinic opened at 9 a.m., we were seeing 20 to 30 patients a day. And As we dressed their wounds, we formed relationships with our patients. And some of you may recognize this is Al-Hassan, who became a Christian and became the clinic groundskeeper. So Al-Hassan was desperate for an amputation, and his wound had grown steadily for 27 years. I thought it was a venous ulcer because I was not very educated in wound care at the time. I now realize it must have been a sickle cell leg ulcer because he got his first ulcer when he was young. And you don't get venous ulcers when you're very young. And it was also excruciatingly painful, which is typical of a sickle cell leg ulcer. He had no other symptoms of sickle cell. So Peter told Al-Hassan, we don't amputate, wounds close under our care. And that's exactly what happened. It didn't close 100%, but you can see how much better it got. It got to where he could wear shoes and he could farm. So his wound no longer dictated his life. So this is another patient. It was all the way down into the low 70s, and so it was really cold. And Hamidou, this little boy, was huddled up against the fire while his mother was cooking something in a big pot, and one of the rocks broke and spilled oil on him, and he was wearing a sweatshirt. So it took time for them to get that shirt off. So he had really deep burns over a large body area. They took him to the local hospital, and the local hospital didn't want to deal with him because he screamed and cried when they tried to change dressings, and so they just didn't change the dressings. He got maggots under his dressings. He was in excruciating pain, and by the time we got him, he had the combination of adhesions under his arm and still open wounds everywhere. And so we did, just basic wound care, nothing fancy. Started out with his cartilage visible between his ribs. It took a whole 2 years for these wounds to completely close, but they closed steadily. I gave him a boiled egg every morning so that he would get protein. And then when he was the rest of the way healed, we sent him up to a charity hospital where they did the contracture release. He has no memory of any of that. He just has the scars. So Asana, who had had the village health worker training, burst into the consulting room to let me know that her brother-in-law, Sadiq, had been killed in an accident and she'd been summoned to collect the body. But when she got there, she assessed Sadiq as she'd been taught in the village health worker course and discovered he was not dead. So she flagged down a passing vehicle, and they took him to the regional hospital in Tamale. They had so little hope for his survival that they didn't even bother to clean the gravel out of his lacerations. They just sutured him. She sat at his side for days, but he had remained unconscious. Now, Peter, we'd had a church member about a year earlier who had been unconscious in the local hospital, and Peter was really frustrated because he knew that if he had dexamethasone, he might have been able to decrease the brain swelling and help him live. And so after that, we always had dexamethasone in the clinic. So Asana sent for the dexamethasone, found somebody to give it, and Sadiq woke up. Then she took him on the bus, don't ask me how, and we opened up those sutures, cleaned out his wounds, and he completely closed and was able to be a teacher again. So that message brought a lot of fame to the clinic and to Christians in general. And of course, once again, he was a Muslim, but we prayed with him at every dressing change. So an elderly Muslim woman walked to the Christian clinic because she repeatedly dreamed that if she came, her massive right foot abscesses of over 3 months' duration would heal. She walked with a stick for support. When I took off the bandages, her smell was very alarming, as was the sight. Now, normally I would have sent her to a hospital, but I had had 2 previous diabetic foot ulcer patients in different locations. I sent one to Corlebu and I sent one to Tamale Hospital, and both of them died before they had surgery. So I said, I need you to go to that private hospital that I told you about before, even though it's in Kokomba territory, and there had been a war not that long before between the Kokombas and the Dogombas, because otherwise you will die. You have to have surgery on this foot. She actually listened, and she went to that place. Oh, I forgot to tell you. So she was afraid of injections because she'd seen the bicycle peddlers give people injections and they'd die. So she would allow us to do a finger stick to check for blood glucose, and of course she had diabetes, but she wouldn't let us give her insulin. So we were just trying to manage her with oral medications, and she would take antibiotics. So, and she, like all our Muslim patients, was very receptive to receiving prayers in the name of Jesus. So, I felt really good about sending her to the hospital and that she was willing to go. I felt like I had done my job. The next day, or in the middle of the night, our room filled with all of her relatives, and Dr. Jean had traveled. There was no surgeon at that charity hospital, and I had told them that if she didn't get debridement right away, she would die. So they came back and said, "You need to do it." I was like, "I'm just a nurse," trying to beg out of it. They did not care. So I said, "Well, after I see my wound patients in the morning, and we have more time, we will see what we can do." She would not accept any injected pain relievers, no lidocaine, nothing. She asked my husband to hold her still. And she didn't have a lot of feeling in the toe area. She had plenty of feeling deep in the tissues. But we rinsed and rinsed and rinsed and rinsed and rinsed. You use sharp to open it up, but then I just rinsed and rinsed and pulled out the dead bones and the dead cartilage, rinsed more, and God being so wonderful with even though she was walking with a stick for support, these pictures go to 6.5 weeks, but she closed in 8 weeks. So, once again, God was glorified. So, another example, despite the fact that Gondogo, which is the Queen's Mother's village, was only a stone's throw away from the church compound, the Islamic village elders there would not permit any of the Christian evangelists to preach there. So the Queen Mother wanted them to be able to preach there, but the elders wouldn't let her. So then this man arrived from Gondogo, and he had chronic wounds that created such a bad smell that the clinic staff all left the building when I removed his dressings. Richard always knew we had a really bad wound case when the clinic staff was leaning over the railing, retching. And so the wounds were not all that big, but they were deep, and they were clearly very nasty infection. So I irrigated all the wounds and applied that polymem, and the man joined the group of about 30 patients who were coming for daily dressing changes every morning. And as the stench decreased and the ulcers started to close, other patients changed his nickname from Stinky Feet to 2 Foot because they were unhappy that it took twice as long to dress his wounds because he had them on both legs. So then he came in one day positively beaming, and he said, "My wife let me back in her room." So eventually he no longer needed my care. And then something quite unexpected happened. The elders from Gondogo came to the preachers, and they said, "We want you to preach in our village." Now, if it had just been me, the credit would have gone to the white person. But because all the clinic staff did this, the credit went to Christ. And they said, "These people are all treating him so kindly, even though he was no relation at all to them, so there must be something special." So many of these stories feature polymem, and that's a problem because that's not a sustainable wound solution. In fact, neither is gauze. Gauze is expensive, it's not available in villages, so we will never get enough donations to care for all the patients that Christians need to help with wound care in all the villages in developing countries. We need a better solution. So 16 years ago, I quit my job and went back to school to get my PhD, which is a research degree. And one of the reasons I did that was so I could help find a sustainable solution to wound problems for village health workers, one that uses only affordable materials that are readily available in villages. I published reviews of the research literature evaluating affordable, available dressing change solutions that had already been tried, and I didn't find anything that might work in the tropics. and it's particularly not in the village setting. Banana leaves and other more organic materials are absolutely covered with microbes, so they use banana leaves in hospitals in tropical areas, but you can't use them out in the village because those people don't know what germs are, so they're certainly not going to do any extraordinary measures to get rid of something they don't even know exists. So we needed to conduct a comparison trial, but no one had described usual practice, so there was nothing to compare. So we set out to formally study what was currently being done and if it was working. And some of you helped us conduct that usual practice study in 25 villages in Ghana in 2012. We confirmed those results in Zambia in 2013 and in different areas of Cambodia in 2014 and 2015. And we learned that just as is true in the United States and in Europe, the people who don't know much about wound care want to keep wounds dry. In contrast, those lay health experts in rural areas of tropical developing countries, just like the wound specialists in Europe and the US, know that the wound needs to be moist to heal. But they are frustrated because they can't keep it consistently moist. They don't have good tools. God designed the body to heal and successfully fight infection, but those systems need moisture to work. So based on that data, we modified the best improvised dressing choice that we could find to make it suitable for the tropics. And we didn't want to be arrogant and assume that we knew everything, and so we wanted to do a randomized controlled trial to make sure there was not any unexpected consequence in the tropics. So we designed a really tight randomized controlled trial to test it, and then we started looking for a suitable study site. And that took another almost 10 years. So when we went to the Sickle Cell Research Unit in Jamaica in 2016, we met this preacher. His name is Michael, and he had a chronic sickle cell ulcer that was very small, but it was so painful when he stood up to preach for very long, he lost the little bit of circulation that he had. Remember arterial ulcers, you lose the circulation when you stand. So he couldn't preach. And God being so wonderful, he was scheduled to preach at the very church that we were worshiping in the very next Sunday. So we were able to talk to him again, and he became our pilot sickle cell patient. He tried all 3 of our study dressings, and he preferred the available technology dressing technique, which is what we call our new dressing, or ATD, because Polymem was less straightforward. You didn't change it on a schedule, and he liked a dressing that you just change every morning. And it was simple for him. And you could change it every morning or every evening, but just on schedule. He teased that he wanted his face on billboards advertising the available technology dressing across the world. So there's his face. So after our success with Michael, I presented the preliminary idea at a conference. We hadn't yet done the randomized controlled trial. And Jordan Yarborough, who's a missionary nurse working in Angola, picked up on it and made notes. And then she was with a group of Angolan Christians going door to door offering to pray with people. And they met a family with a serious spiritual and physical needs. She said, well, when she walked up to the house, it just felt like there was evil inside that house. And they went inside and they found out that a young man had had an abscess, and his mother had consulted the spirits, and she thought that the spirits told her that she should pour boiling water on his arm to cure the abscess, which he did, and it opened up that abscess all right. You can see how big his wound was, and then he had undermining going all the way up from there. And it was nasty, super infected when she saw it, full of thick pus. So the witchcraft wasn't helping, obviously, and the nasty infection was spreading, and then the Christians knocked on the door. And God being so wonderful, Jordan knew that a surgeon who could perform skin grafts was going to be in the area in about 10 days. Now, this does not look like something that's going to be ready for grafts in 10 days. But we prayed a lot, and she used the available technology dressing. You have to have it clean and granulating. Just clean isn't going to hold a graft in place. It needed to be granulating. And you've got muscle tissue showing there. So she applied clear plastic food wrap, because that's what she had, to promote autolytic debridement. And this picture is from day 2, so it's much cleaner on this picture. And the one below that is from day 9. The grafts took beautifully, and he decided to be baptized. So we conducted the randomized controlled trial, and we compared usual practice with the only advanced dressing with a good track record in the tropics, which is Polymem. Our usual practice benefited from much better wound management than usual practice really is, because most usual practice sticks to the wound bed, and we weren't willing to go that far. So we used fluffed gauze that we made really, really wet with saline and put dry gauze over top with it, and the goal was to keep it so wet that it was still damp at dressing changes and wouldn't stick. So that was our usual practice group. So that already is much better than what most people do. And then our available technology dressing, I'm going to go into detail on in a minute. And then the third one was Polymem, which is a really advanced dressing, and is pretty much the gold standard in wound care. So we didn't compare against something ordinary, we compared against the best we could find. So we used soda bottles, this is my husband's great idea, to create a sustainable irrigation system. Don't use water bottles, they're not strong enough. Cut a hole, poke a hole in the top with a hot bicycle spoke. And then you squeeze the bottle to produce a strong stream of saline for irrigating the ulcerate dressing changes. You want that stream to be at an angle so it pushes the germs out. You don't want to go straight down because then you're pushing the germs down into the wound bed. You have to teach the patients every single step very carefully. Demonstration, return demonstration, because they will make mistakes you didn't even think of because they don't understand why they're doing what they're doing. But we were able to teach even some pretty intellectually impaired patients how to do this technique. 1 capful is the right amount of table salt to make normal saline. If you like to use normal saline, it's not really necessary. A paper makes a good funnel if you want to do that. If the patient does not have access to clean water, you can use solar water disinfection. And if you don't know what that is, you need to come talk to one of us and we'll tell you. But basically a bottle with water that's clear enough that you can read through it out in the sun for 6 hours, or in cloudy days, two days, okay? Then, so you're going to clean the wound really well. If you're at a good facility where someone can do sharp debridement, initial sharp debridement is best. But if they can't do initial sharp debridement, just irrigate. We were doing this study during the pandemic, and therefore there were restrictions on us, and we weren't able to do sharp debridement on, we only did sharp debridement on 1 participant of all of them. So even if you don't do sharp debridement, autolytic debridement will work, it's just slower. So the plastic dressings that they used in Japan and later in the USA are not really suitable for the tropics as is, because they wrapped it, and that's way too hot for patients. They tried that in Jamaica and they couldn't tolerate it. And you're going to get fungal infections under that plastic. So we modified that. You can see these plastic bags. Have you ever seen plastic bags like that for sale in the market? I'm sure you have. I have some that I forgot to bring up here to the podium that I can show you afterwards. It's just the thin plastic bags like you use when they're selling water or rice or soup or that kind of thing. You can use other shopping bags. We've tested them, and the colored thin plastic shopping bags work as well. But it's nice to have them clear because you can see through them. And if you buy a bag of bags, they're totally, absolutely clean. This plastic, the germs hate it. Unlike the banana leaves, you don't have to worry about these being dirty. So that's a big advantage. You're going to need something to protect the wound edges, because you're going to create autolytic debridement, and you're going to produce extra exudate from what you had before. So if you had a heavily exudating wound, you got to give your patient the bad news. It may be even worse for this first week, but after that it's going to get better. You know, once the autolytic debridement has cleaned up the wound, then you're going to start decreasing the inflammation, you're going to get granulation, and the amount of fluid it produces is less. But the entire time you're using the available technology dressing, you need to protect the wound edges, and you need to teach them that that's what they're doing, because autolytic debridement produces proteolytic enzymes, enzymes that digest protein, and they will digest that skin if you don't protect it. So you can use zinc oxide paste, shea butter, whatever it is that the local people use for babies' bottoms, that's what you're going to use on that wound edge. And you have to teach the patient that that is not dangerous in the wound bed. The goal is not to fill the wound bed with that stuff, but if a little bit of it accidentally gets in the wound, it's not poison. It will be okay. It's not like an antiseptic, okay? So you're going to cut that plastic wrap after you put the wound ointment on. You're going to cut that plastic wrap slightly bigger than the wound bed, and then you're going to cut slits in it for the extra fluid to escape, and it's just going to burp out as those slits open up to let it out. You don't want holes, just slits, because you want it to stay moist and covered. So if it's on the leg, one of those slits need to be the closest to the foot, and if it's an arm, one of those slits needs to be the closest to the hand, so that the drainage will drain out and not go down, try and go underneath the plastic, okay? And that'll also seal that plastic to the wound edge, okay? So it's very important that the plastic is against the wound bed, and so I tell the patients that there are a lot of very small animals. They're not spirits, they're real physical animals that are very tiny, and they are trying to hurt their wound, but their body produces, God being so wonderful, very small hunters to kill those very small animals. So if you can create a path by making the plastic be directly against the wound bed that is wet, so that that hunter can move very quickly, because the hunter needs fluid for food and for movement, then it can capture and kill all those animals. But if it's dry, or if it's a pond, then the animals have an advantage and the hunter will not be able to get them all. And they understand that and will do what you say if you explain it that way. So we sent, over top of that plastic, you put an absorbent, and the absorbent that you use is whatever absorbent the women use for their menstrual period is probably the cheapest non-toxic substance. If they use cloths, they can wash them and reuse them the way they would for their menstrual period. Okay? I always tell people putting things out in the sun kills germs, so after it's as clean as you think you can get it, put it out in the sun and it'll kill whatever other things didn't. God being so wonderful, He even gave us a sterilization system. So we sent weekly photos to blinded outside reviewers to make sure that we were not missing anything and that we weren't somehow cheating. And as you can see, this first wound has got greenish to it, and that's Pseudomonas, and they were in the usual practice group. These next ones, we learned that old telephones sometimes, old mobiles, will sometimes distort the colors. So we'd message on WhatsApp, and we'd message the patient and say, does it look green to you? You know, and does it smell to you? And then we'd have them come in if we were in any doubt to make sure that it didn't have Pseudomonas. And as you can see, clearly it didn't have Pseudomonas, because we didn't do anything to kill Pseudomonas. It cleaned right up. So so he was doing well. But he kept on insisting that, no, that's just my phone. Everything looks green on my phone. So this is Leifert, and he wanted me to be sure to include his story. He lost one leg to a sickle cell leg ulcer, and then he got a sickle cell leg ulcer on the other leg. You can imagine how panicked he was. He didn't want to end up in a wheelchair. He was a carpenter. So he lives alone. He didn't have a smartphone to send pictures, and he was illiterate, so he couldn't send text, but he came every single week so that we could monitor his wound, and he did his dressing changes every single day. And as you can see, he got really good healing in the only 12 weeks of the study. So he was really, really happy to be empowered to be able to change his own dressings. And you can see it also cleaned up the wound really nicely. So although the available technology dressing technique is flexible, the instructions have to be followed exactly to promote healing and avoid complications. Clean and debride as well as you can initially, and then do not scrub it with saline and gauze or anything like that, because you're going to increase the inflammation. Inflammation is not your friend. So, and you're going to damage that fragile new granulation tissue and increase the risk of infection. So our study protocol was for daily dressing changes with a strong saline irrigation at each change. It could be that every other day will work once the wound is really clean. We do not know. If one of you wants to do a research study, you can use my protocol and just make minor operations. I'm happy to have you make minor changes to it and publish that study, and that would be a big benefit to the world. So let's see. Let's see. We really had trouble explaining the cutting the slits instead of holes to the patients. So be sure they understand that. If they cut holes, their absorbent is going to stick to the wound bed. And it's also going to tend to dry things out. So the final reference on the slide deck here, which you will get copies of, or your professors will, goes to an article in Community Skin Health, which is a journal especially for healthcare providers in Africa. And this is a snip from the instructions for teaching church leaders how to do the available technology dressing technique so that they can pass that along to other people. And that article was specially laid out so that you can tear out that one page and fold it in half, and it's a brochure. So the results of our study show that wet to moist dressings had 25% infection rate, whereas both available technology dressings, or ATDs, and Polymem had 0. And Polymem is a pain relieving dressing. It alters the nociceptor response, so you would expect it to be really good at pain relief. But if you look at just how the ATD compared to the usual practice caused the ATDs reduced the pain to half what it otherwise would have been compared to usual practice. So it was pretty dramatic in its pain relief as well. This is a complicated slide, but the vertical lines are the 0 mark, and the wounds that close by that percentage are in the dark colors. So as you can see from the yellow usual practice, we actually had more wounds get bigger on the right than get smaller on the left. And by a greater percentage. Whereas the middle one is the ATDs, and you can see that almost all of the wounds got smaller rather than bigger, and some of them got dramatically much smaller at the far end of the graph. The polymeric membrane dressings, or Polymems, had more wounds that closed completely, but it really didn't outperform the available technology dressing by that much. And then costs, I'm not going to go into that in detail, but the saline soak gauze actually costed twice what the available technology dressing did, because if you want to keep the wounds really moist, it uses a lot of gauze. So that was, even for the bigger wounds, it used very little. So when Muslims leave their traditional religion for Christianity, they lose their family, and that's not a problem because they gain the family of Christ. But they also lose their healthcare system because they're no longer going to the witch care doctor or their religious leaders. So they need to have that replaced as well. In the Old Testament, people went to the priests. We're not asking you to teach your preachers or preachers' wives or somebody in every village to become a medical doctor. But we do need to teach them basics, and basic wound care is one of the best things you can do that has the most bang for the buck. So in summary, I'm pleading to you to take time to incorporate healing into your, wound healing into your practice. If you don't see many patients, they probably don't know you're doing wounds. I can't emphasize enough the importance of praying with every patient. We need those patients to know that we dress wounds, God heals them, and that prayer is a gift that you can give to them. And the references are below, and you will get a copy of the slides if you like it. So thank you very much.
All right, if you have one question, urgent question, otherwise you can see here. Okay, there is one.
Thank you. Do you find that if you don't graft the dressing of the wounds, that you get scarring and contractures?
If you have the ability to get grafts done, grafts are always better, because remember how I talked about how scars are inferior tissue? When you do grafts, you can replace that vacant area with good tissue that has the fat and that sort of thing in it. So it's much better if you can graft. The problem is that out in the villages or the remote areas, oftentimes those people are unwilling or unable to get to a location for grafts, and I'm mostly talking about the rural and remote areas here. If you live in Kumasi or Accra or Takoradi or Cape Coast or somewhere nearby like that, then by all means do as Jordan did, get that wound fully granulating and then send them for grafts.
Okay. Oh, there's one urgent one as well.
Thank Thank you. Please, I would like to know, are these methods effective in cancer wounds as well?
So we have a session tomorrow on preventing and managing wound infection, and cancer wounds very easily become infected. And you can deal with the infection, but the cancer wound itself, these are not going to help with that. So unless that cancer is fully excised, and some cancers can be and some cancers can't be, you're not going to get rid of that cancer wound. So these methods are palliative care. They can make the patient more comfortable and make it not smell so bad so they can be around people as they die, if they're going to die of the cancer, but it's not going to get rid of the cancer.
All right, so that will be all for now. Thank you very much. You can see Doc outside, and then you can ask further questions. All right, so we need to go for lunch now. So those lodging at Farmington House, the guests from the US and other countries who are lodging at Farmington House, you will have your lunch there. And those from the Church of Christ Health facilities will have your lunch where you usually have your lunch, I mean your meals. That's the CEP kitchen and canteen, sorry. And other attendees, you can also buy your food from the canteen just behind the auditorium. And we'll be back at 1 o'clock so that we'd have the next session. So thank you so much for your time. I'll see you at 1.
My name is Kevin Linderman. I'm the Executive Director of International Healthcare Foundation, African Christian Hospitals, and our ministry has for 40 years been sponsoring a medical missions seminar here in the USA. And out of that seminar, many medical missions have started, and our own ministry has been able to expand in many countries across Africa. And I'm so excited to invite you to our first time ever hosting this medical missions seminar on the continent of Africa in Accra in partnership with Heritage Christian University. We really hope that you're able to come and attend and be inspired, be encouraged, and to see a pathway forward in joining God in His work through medical missions. I look forward to seeing you in Accra, May 22nd through the 24th.